Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here today with my coffee-drinking, energy-deprived co-host, Dr. Jay Calvert. How are you?
I'm enjoying this coffee from our local coffee spot there over in Beverly Hills.
La Colombe.
Very tasty.
We like it. Whenever we can get there in the afternoons, it's always a nice treat.
It's good. I have to tell you the truth that I'm afraid of this podcast, and so I need some rocket fuel to get it going, because when you suggested it, I just went, okay, let's do it.
Yeah, that's how I feel when you suggest things like cleft nose repair.
So, touche, we're on.
Which is why I had champagne last week. So.
It's always good to be drinking for those tough podcasts. But this one, I'm drinking some coffee so I can keep up.
Yes, this is the Tuberous Breast podcast. Ooh, the crowd went, ooh.
Ouch.
Except the crowd mostly has no idea what
No, but
that
the
means.
plastic surgery crowd all went, oh, okay, let's do it.
So a tuberous breast, I think we've done this podcast before. Actually, I know we have, because I actually had a patient today coming in for a tuberous breast consult, and she referenced the podcast. So it's out there, but I think we need a revamp because it's been a couple of years. So what we are talking about here is what's called a tuberous breast, otherwise known as a constricted breast, also sometimes called a congenital breast deformity or asymmetry. So this is, as it sounds, it's a congenital, I hate to use the word deformity, but aberrancy in development of the breast. And there are multiple grades of the tuberous breast, but the classic finding in all of them, to various degrees of severity, is that the lower portion of the breast, we call that the lower pole, is underdeveloped. So the top part of the breast, the part that's sort of from the nipple and up, usually develops fairly normally, although there are instances where it doesn't develop at all either. But usually that part develops fairly normally, but then the lower half, the part that sits below the nipple, instead of having a nice rounded shape at the bottom, it literally has these bands internally called constriction bands that narrow it and tighten it. And that distance from the nipple to the bottom of the breast is very short. And the fold of the breast, that's called the IMF, sits higher than it's supposed to because it also didn't develop properly. And so that's sort of the genesis or the properties of a tuberous breast.
And they don't look cute at all. That's the problem. So this is what brings the women in, is that they're saying, like, I don't like the way this looks. It's usually a very herniated nipple areolar complex as well, where the tissue behind the nipple areolar complex is sort of pushed through the skin envelope. They can kind of look.
It kind of gives them that cone shape, or the tuberous shape that they're talking about, is that cone shaped. Because what happens, so the pathology here, and the reason it's called a constricted breast, is it has those constriction bands that just mentioned. And when you are in the operating room and looking at them, you can see them and you can feel them. It's not a microscopic thing. They are literally these hard, fibrous bands, usually on the bottom half of the breast, that are constricting it from developing properly. And until they're released, the breast stays kind of cone-shaped at the bottom. Now, the nipple and areola are usually uninvolved by this process, and that areola skin is very stretchy just at baseline. So when the breast develops, it all goes into the areola because that's the part that can actually grow and stretch, because the bottom part can't. So that's why they get that kind of cone shape, because the areola is nice and stretchy, and it'll stretch out to the size it needs to be at the expense of the lower portion of the breast.
Yeah, and this is and there are different gradations, and it's depending on the grade of the tuberous breast deformity, the difficulty and the algorithm for reconstruction becomes more relevant, and it's something that you really have to get on board with somebody who's skilled and experienced with this problem.
Yeah, and the different grades aren't super pertinent to the podcast, but things to know is that at its most mildest form, the patient may not even realize that there's a appearance difference in the breast. Sometimes even the plastic surgeon doesn't realize it until sort of afterwards. And it's
they miss it.
Yeah, I kind of miss that. And it can be very subtle and probably more common than realized, where that lower pole just has more of a cone, narrowed shape to it than the rest of the breast. And it doesn't have a nice, smooth, round, half moon lower half. It's just a little more like angular. And that's not as big a deal. You just kind of have to know that it's there and address it and maybe do a few changes to your surgery. But then from there, it can get more and more extreme. And one of the other findings with this is that the breast can be very asymmetric. So one side can develop normally, or it might have the tuberous breast deformity but be a large breast, and the other side might not develop at all, or it might develop to be half the size of the other breast. And so those patients obviously know there's a difference, and they'll come in usually earlier, in their teenage years when their mom or their pediatrician recognizes that there's some kind of asymmetry. Some of these patients come in like their 30s, and they're like, yeah, I just, thought it was kind of weird, but I didn't really want to do anything about it.
Yep.
So it's not uncommon. So that should be another red flag to a plastic surgeon when they see breasts that are really different. It might not just be that one developed less than the other. It might be that they both have this shape difference.
And in terms of the way to correct it, I mean, there's a lot of different approaches, and we can, kind of start from the easiest, obviously, is kind of doing a breast augmentation or fat grafting. Those are sort of the things that I think of for the mild forms. You're going to do something to, like when you do the breast augmentation, typically I think about doing a biplanar where you release the gland from the muscle. You might even just do a subglandular augmentation, scoring of those bands, getting, release of that breast tissue so that it does spread out over the implant. And hopefully the implant can fill in the deficit tissue of the lower pole. Lowering the inframammary fold can also be part of that plan, depending on how long or short the distance is from the nipple to the inframammary fold. But they then get more severe, where you start to talk about tissue expansion and other methods. When do you go to tissue expansion with tuberous breast deformity?
I usually would only consider a tissue expander if one or both of the breasts are like completely not developed. Or if one breast is significantly smaller than the other. Like maybe they're like a D or a double D on one cup and like an A on the other side. And the skin is just tight. In that case, I'm never going to be able to get that A cup side to look like the D cup. So I need to stretch the skin. But in general, I don't have to do that. I think I very rarely go the tissue expander route. Sometimes I'm thinking of one patient, she had implants and I had to go back to tissue expanders because she just kept failing the implants. And the constriction just kept coming back, and her nipple was like all the way up by the clavicle, and I needed to recruit some skin, and it was a whole deal. And put the tissue expanders in, and it was great. They did the trick for her. But usually I can do the job with an implant. And for those milder cases that you mentioned, a lot of times that's what the patients come in asking for. Like, I just want a breast augmentation. They kind of recognize that their breasts aren't as cute as maybe they could be, and they think the breast augmentation might help. And so those are the patients you really have to educate. Like, hey, I know you just came in because you want to have larger, cuter, more perkier breasts, but like this is what's going on, and it's going to be a much bigger deal to address it. This is not just a classic breast augmentation. You're almost more in a breast reconstruction category, and they can all be done. They just have to know that they're in a little bit different category. And I do the same things that you do, that you talked about. The main tenets being that if that fold is sitting high, if that distance from the nipple to the fold is very short, you have to lower the fold. If you don't, the implant's going to sit at that high fold, and the nipple is going to sit at the bottom of the implant, which is not cute. You want it nice in the middle. That's where the nipple should sit, right in the middle. And if that distance from the nipple to the fold is very short, it won't do that.
No.
So you got to lower the fold and sort of bring the nipple into a proper position relative to the implant. And that alone is very tricky. Anytime you're playing or adjusting with the fold, it keeps its memory of where it should be, because the fold is a very distinct structure, and it goes all the way up to the skin. It wants to keep that crease. And so you have to obliterate it completely. And then once you've put it in a new position, you got to keep it there. Otherwise, it can continue to fall over time if you don't fasten it really securely with internal sutures and do postoperative bras and all of this stuff. So messing with the fold on its own is no small thing.
No, and especially if you're going to try to put an expander into the space where the fold used to be.
Yes.
So that becomes a real issue because the inframammary fold, just when you look at it in a cross section, like on a microscope slide, if you do like a histologic sectioning of it, it's a very thickened structure.
Mm-hmm.
It's the fibers of the skin and the dermis and the underlying soft tissue. They
converge.
They come together and make a real structure, much like a nasolabial fold. This is a real structure on your face. Similarly, the inframammary fold is the same deal.
Yeah.
And so when you try to stretch it's not up for it.
It's not designed to do it.
No.
And so that is one tricky area. The other tricky thing are those constriction bands we talked about. Those have to be released. And those constriction bands go all the way up to the skin as well. So you really have to do a full thickness of the breast release of those bands to allow the breast parenchyma, the breast tissue, to expand and become not so constricted. And so really the breast implant is kind of incidental to the whole surgery. The whole surgery is really reshaping and recreating the shape and the footprint of the breast. Then the implant just goes in to sort of splint it into that new position and provide the volume that they're missing, whatever size they want to be. And in terms of where and what plane you put the implant, the traditional teaching is that you put it directly under the breast. So implants can go under the muscle. This is the pectoralis muscle, or they can go over the muscle. That's called subglandular. For these, this is probably the only time I will do a subglandular implant. In general, I do not like subglandular implants. That's another podcast. But this is the one time that I will do a subglandular implant because for that reason, it splints the breast into that new position. And I find I have better postoperative control of that IMF. If I've put it under the muscle and I've released the old IMF, every time the muscle contracts, the IMF can do some weird, funky things with the muscle. So I've just found that by putting it over the muscle, even if the IMF retains some of its memory, it's not as dramatic as when the patients are moving and flexing their muscles. It doesn't change as much.
Yeah, I mean, I like subglandular implants in general. If there's any kind of coverage, I don't hesitate to go subglandular. I mean, people talk about capsular contracture rates and all those sort of things. I find that the benefits of being subglandular in even a routine AUG can certainly outweigh those risks, which are hard to really measure as truly differential. Right. But in tuberous breasts, you're right. Putting them subglandular, way better. Trying to do a biplanar AUG or something like that, which is what I've seen done in the past, tends to be really, really tricky, and it seems like you're going to be back there again.
You have some problems. And then the other thing, so once you have your, you've created the pocket, the shape, the position you want for this new breast, you've put in the implant to give you the volume and keep the breast open, then you have to talk about the nipple and the areola and what you're going to do with that. Because a lot of times they need some kind of lift. And even if they don't, I usually still do some kind of areola reduction because I have found that if I don't, that areola spreads and widens and kind of takes over like the whole breast. Because the breast is used to being kind of tight. And again, that areola is very stretchy. And then you put an implant in and you stretch it out even more. And it can take over the breast. So I usually try and just cut around it and put some sutures in and reduce the size preemptively.
Yeah, you can get some real, I mean, I've seen some gigantic areolas that really, like you said, they dominate the skin of the breast.
The breast.
Yeah, it's true. And that's not unusual in that situation. It really does stretch out a ton. And,
because I think because when it does herniate, it stretches, and then it herniates, and then it stretches. And so
then you release it.
And then you release it, and then all of a sudden, like, it's the whole breast. So I usually do something, especially because sometimes patients are, like we said, asymmetric. So one side does need a lift and the other side maybe doesn't. And so if I do a lift on one side and I cut all around the areola and I put the sutures in and I don't do anything to the opposite side, that side expands. And the one that I did a lift on doesn't. And now the areolas are asymmetric. So that's just what I started doing.
38 millimeters to 40
5.
to 45 millimeters is good. Once they get into the 10 centimeter range, you've kind of,
It's too much.
it's dominated the
Yeah.
breast. Yeah, and I have to tell you though, I had a patient one time, she came in for a breast aug and she just had gigantic areolas and they literally were like kind of dominating the breast. And I was like, do you want me to reduce those? She's like, are you crazy? I love those. I'm like, so you got to ask.
That's true.
You do. You have to ask.
Yeah.
And she's like, oh no, I love them. They're so pretty. And I was like,
Then I love them too.
then okay, then we'll just do this differently. But yeah, you do have to, everybody's got their own idea of what beauty is to the, on their breasts. And especially if their breasts have been tuberous their whole life, then it is sort of it's a changeover. It's like, okay, well, this is what I'm used to. And that's kind of like that happens in rhinoplasty and it happens in body reduction surgery where people are like, well, wait, I don't want to look too different.
Yeah.
Like this is my body. I'm used to this.
I see that in breast reductions a lot.
Yeah.
I want it. Whoa.
Wait, where are my breasts?
Yeah. Where did this big stomach come
And why
from?
do I have this big belly? Oh, I had a patient at West Penn Hospital when I was a resident. She came back after her breast reduction, and she was madder than a hornet. She was fuming angry at me. I go, oh, so what do you think of your breast reduction? She goes, Dr. Calvert, you did a great job on my breasts. I got a bone to pick with you, though. Who put this belly on me? You put this belly on me when I was in surgery because I didn't have this belly before. I was like, well,
But
I
did.
just reduced the breasts. I didn't stick them into your belly. And it's like, as soon as you uncover it,
There it is. You can see it.
then they're like, oh, do you think this is funny? I mean, she was so angry with me. And I was like, it was there.
Yeah.
I didn't put that there. That was just hidden below the deep
breast
to the
tissues,
under the sleeping bag of breast tissue that covered the entire abdomen. Now you have
Now
your
you
belly.
see it.
Sorry.
That happens. And so any change on the breast, patients can sometimes get weirded
Yes.
out by for any reason. But the tuberous breast, that's sort of the deal. That's sort of the basic of surgeries you do for it. I have had patients who really just didn't want implants, and implants are sort of the basis of how we treat the tuberous breast asymmetry or deformity. But some patients just, for good reason, just don't really want to have a lifetime of implants. They just want to correct the asymmetry or the constriction deformity. And so I've had that talk about doing lifts and fat grafting. I don't love it. It has to be a very mild case because unless you surgically release those constriction bands, the skin itself is never going to expand.
Nope.
It's not just that one breast is smaller than the other. If that was the case, then yes, maybe fat grafting and a reduction on one side would do the trick. But when the problem is that the internal anatomy is so constricted, fat grafting is not going to camouflage that, and the skin won't stretch and it won't expand. You have to go in there and release it. And if you release it, then you have to put an implant in. Otherwise, it'll just scar back down to the place it was before. So fat grafting on its own, not a great option unless it's the mildest of mild cases and you're really just trying to correct a size, difference between the two.
In your general sort of practice of treating tuberous breast deformity, where does fat grafting fall on that scale? Is it in every case that you're doing some fat grafting? Is it in half the cases, 10% of the cases?
It's not my go-to for the first round of surgery. I have had to do it for revision cases, and that's a very important point, is that of all of the breast augmentation cases we do, this one's probably the highest chance of having to have a revision. And I tell that to every patient. Because again, you have to think of this as a breast reconstruction almost. There is most likely going to be some kind of residual something that needs to be addressed. And it might be very mild and you don't care about it and you can live with it. But sometimes you need like a little tweak on something. Maybe that IMF didn't sit exactly where you wanted it to. Where I've used fat grafting is if that native IMF has retained its memory. A little fat grafting to camouflage that works really well. So I use it more if I need it for a small revision than I do in the primary surgery.
Same. I feel the same way. It's like I'll use it in the primary surgery if it's useful. If it's useful
Yeah.
around the around the cleavage or
Yeah.
upper pole, I find some fat grafting there is really nice. But yeah, it's much more of a revision kind of move.
Right. So that's the more or less the take home of the tuberous breast. Important points are that this is not a basic breast augmentation. It's going to be a little more involved. The risks of everything are a little bit higher. The chances of complications are certainly higher. And the chances of needing a revision are higher. And the revisions aren't usually big undertakings, but you may need a little tweak of something. And that's, not uncommon.
Well, I tell the patients to think about it as a staged reconstruction. I usually say you're going to need 2 operations. Now, if you don't need the second one, that's great. But I would think about it that you're going to need 2. This way, at least we get it looking great in the first round of the operation. And if you need some sort of adjustment, fat grafting or whatever, that's part of the deal. Because it's not like things went wrong or it didn't work out. It's just that it's a very complex situation with a lot of moving parts. You talked about short distance from the nipple to the inframammary fold, elevated inframammary fold, no tissue, herniated nipple areolar complex, too much volume in the upper pole, asymmetry. So each one of those things need to be addressed, and each one has its own percentage need to be adjusted.
Revised, yeah.
Maybe it's 1 to 3%. Well, you take 1 to 3%, 6 factorial times. It's like, think about it.
Yeah.
You can't get everything right every time because it doesn't balance out of the gates. And so I think if the patients understand that they're in a reconstructive situation, they're going to be much happier working towards the goal of having really nice looking breasts.
Right. Versus just like, hey, we're going to put some implants in you and you're going to love it and you're going to look great and high five.
That's right.
No.
That's not how it works.
That's not how it works. But you still can make them look really pretty.
Absolutely. And you do a great job with these. So I highly recommend Dr. Millicent Rovelo for tuberous breast deformity any day of the week.
That's what I do.
Absolutely.
Well, I think that's it for the tuberous breast deformity. Thank you, Dr. J. Calvert, for hanging in there with me. And this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.